Good morning. My name is Andrew Browne. I'm an assistant professor at the UC Irvine Gavin Herbert Eye Institute and also spend about half my time doing research in the Department of Biomedical Engineering. Today I'm going to be talking about eye care beyond black and white. In other words, how do we evaluate people's vision rather than just using black and white or white tests? And because I'm a retina specialist, I'll be speaking specifically about several different macular diseases. These are my disclosures. This is a diagram of the eye, and when we look at the eye in cross-section, we can see the retina in orange covering the back wall of the eye. And this is a diagram of the retina where we have the optic nerve, the blood vessels, the central vision being served by the macula in the center of the retina, and the peripheral vision being served by the more eccentric parts of the retina. And this is a scale model of the retina. In fact, a postage stamp from the United States is about this size, and it's this relative size compared to the retina. And this, of course, is a color fundus photograph of the retina. If we're talking about the fovea, which is where we spend so much of our clinical time caring for patients and paying attention, we're talking about a very small area. It's only 1.5 millimeters in diameter. And if we look at it in cross-section, we can see the classic foveal umbo on an OCT image, where we can also see multiple individual layers of the retina. And this small foveal umbo is what is responsible for so much of our vision. In fact, even though the fovea is less than 1% of the total retinal area, approximately 50% of the visual information that goes from each eye to the brain comes from this very small area. If we were to take ballpoint pens and a fine ballpoint pen, which is about 0.5 to 0.8 millimeters in width when you draw with it, it easily covers the most high acuity area of the central vision. So this is an incredibly small area. When we talk about measuring visual function, so much of our effort is put into visual acuity testing. And here we see an ETDRS chart, which is the gold standard for clinical trials for visual function, especially in diseases affecting the retina. We, of course, also have the visual field exam, where multiple points across the retina are tested for sensitivity. And then there's also the Amsler grid. One of the things that's worth noting is how much of the retina do each of these tests cover. So if we take that color fundus photograph and we overlay the visual field, we can see that the visual field truly only tests the most posterior part of the retina, including the macula and the very near periphery. So we're largely excluding the most peripheral parts of the retina with the visual field. With the Amsler grid, we go to about 10 degrees of central vision, and so this is an even smaller area. And then, of course, with ETDRS letters, if we take a 2200 letter and a 2400 letter and a 2020 letter and overlay it on the retina, you can see how small the area is that is being evaluated with visual acuity letters. So these tests are all black and white, as you can see. And if every day I walked into a building that looked like this, that would be fine. But this is the Gavin Herbert Eye Institute where I work, and it's in color. And there's many hues, and there's contrast, and there's many other elements to vision that are important. And so when we think of color vision testing, we of course think of the Ishihara color plates. And today I'm going to be talking about cone contrast threshold testing. So to start off, we look at the diagram of a retina in cross-section, and we can see the photoreceptors at the base of the retina overlying the retinal pigmented epithelium, which is responsible for allowing this area of the retina to turn light into electricity. And all that information is conveyed through the middle retina until it gets to the retinal ganglion cells, which all converge and go through the optic nerve to the brain. When we speak specifically about photoreceptors, we think about opsins, the proteins that are responsible for allowing light to be turned into electricity. They are the first step. And so we think about the S opsin, which is the short wavelength opsin, the medium and the long wavelength opsins. And then, of course, there's rhodopsin, which is what we typically think about for night vision and peripheral vision. But rods and cones are found throughout the fovea and the macula. But the fovea is predominantly rods, so a lot of high acuity color vision in the fovea. If we look at the specific proteins, these opsins, and what wavelength do they respond the most to, what we can do is we can look across the visible spectrum, going from very short wavelengths of light in the ultraviolet realm to the longer wavelengths of light extending to the infrared realm. And we can see that the short wavelength opsin, S opsin, responds at a peak of 420 nanometers. Interestingly, the Rudd opsin actually has a kind of a bluish-green response hue. And then, of course, there's the green and red M and L opsins. Not all photoreceptors are exactly the same either. So if we look specifically at the fovea, the cones, which are very dense in the fovea, have a very interesting morphology. They are long, skinny, and they can be packed very densely. But cones, as they are moved further and further away from the fovea, they become shorter and fatter. And this is proved by looking at histology, where we look at the cones in the fovea here. This is a histological cross-section. And then the cones in the periphery, we can see these as these larger, fatter cells that are separated by a whole large collection of rods. Adaptive optics, scanning laser ophthalmoscopy, can show these exact same features in vivo. So we see a large number of highly packed, skinny cones in the fovea, and the cones in the further periphery are much fatter and shorter. Of note, when we talking about the fovea specifically, the central 2 degrees of the fovea have got no S cones. So basically, there's a scarcity of any blue cones in the central fovea in the central 2 degrees, whereas green and red cones, the S and L, sorry, the M and L cones are throughout the whole macula, including the fovea. A lot of times people ask me about different animals, and because I spend about 60% of my time in a basic science and engineering lab, which I run, I do work with different animal models, including zebrafish, rats and mice, and in some cases, pigs as well. And when we look at these cross sections of the retina from different animals, we can see that there's a large difference between the human or primate retina and the chick and zebrafish retina, and everything in between is very different as well. So the gray circles represent rods, and the colored circles represent cones. So you can see the relative distribution of rods and cones in these different species. Only humans and primates have a fovea, whereas dogs and pigs have a macula centralis, which is more cones than other animals, but not a true fovea. So there are cone-dominant species and there are rod-dominant species. So typically cattle and rodents tend to be rod-dominant species, whereas humans and dogs, etc., are cone-dominant species. If we look at zebrafish and chick, they have even different wavelengths that they can respond to that we can't see, including ultraviolet. And then, of course, there are cross sections that en face views of the retina in these different species, which can all look so incredibly different as well. I work with retinal stem cells, human stem cells that are differentiated into retinal organoids, which will hopefully one day be used for transplantation in blind eyes. And we can see a human retinal organoid here. And then I also have done some work with zebrafish, where we can see that the zebrafish has got this characteristic layered structure of its retina, just like a human, but the retina responds to very different wavelengths of light. Now I'm going to return to talking about photoreceptors and the retinal pigmented epithelium that lies below the photoreceptors, and that is responsible for helping photoreceptors continue to be able to respond to light. This is a fairly complex diagram that I will go through quickly, but the takeaway point is that there are many different proteins and enzymes that help the ability of the retina to turn light into electricity occur over and over again and very quickly throughout the day. So vitamin A is brought from the liver and delivered to the retinal pigmented epithelium from the blood. This comes as one of these vitamin A derivatives that is rapidly cycled through the retinal pigmented epithelium and transported into the photoreceptor, where it binds to one of these opsin proteins. These opsin proteins are the ones that we were talking about before, the ones that initiate the conversion of light into electricity. When light touches the opsin protein that is complexed with one of these vitamin A derivatives, it changes its shape and vision begins. The vitamin A derivatives are then released, and they have to go through a whole series of other proteins and enzymes in order to be recycled. So we see a cycle of many complex enzymes and proteins that allow vitamin A derivatives to be recycled over and over again very quickly. This is true for both rods and cones. Cones have a special relationship with a different category of cells, Macular cells, which are found in large number in the fovea. And so the cones are able to work with Macular cells to recycle vitamin A derivatives via a different mechanism in order to allow rapid recycling of these derivatives so that vision can occur very quickly in the fovea. This is a very complex diagram, and so it's not worth trying to memorize it necessarily unless you are a scientist who's interested in studying it. But the takeaway point is there's a lot of different enzymes and proteins that are responsible for this rapid cycling of retinoids. In retinitis pigmentosa, which is a relatively common hereditary blinding disease, there are mutations that occur in so many of these different enzymes and proteins. Similarly, Leber's congenital amaurosis affects multiple different enzymes and proteins. Stargardt's disease is typically associated with ABCA4. Fundus albipunctatus has got its associations with specific mutations, as well as retinitis punctata albicans or Doyne's honeycomb macular dystrophy. So there are these hereditary diseases which we often, from a clinical standpoint, do think about checking color vision as part of the standard care. But not all patients that come into our clinics are having their color vision or their contrast vision being evaluated. They're only really having their visual field or their visual acuity checked on a routine basis. If we go even further into the relationship between the RPE and the photoreceptors where light is turned into electricity, there are a whole series of other proteins that are also responsible for this phototransduction process. And these can be mutated to cause blindness as well. So when we're talking about color vision, we have normal color vision where you can see the full spectrum of the rainbow and all the hues in between. People who have tritanopia have lost completely of the est cone opsin, meaning the short wavelengths. Deuteranopia loses green, protanopia loses red. And similarly, anomalous opsins result in a slight reduction, but not a complete reduction like the anopic version of these color deficiencies. Blue cone monochromacy might look like this, and achromatopsia has no color hue perception. When we talk about the specific test for color vision testing, the clinicians in the audience will quickly recognize the Ishihara and the Hardy-Rand-Rittler color plates. We've probably all taken one of these tests before because they're very quick, they're very easy, and they do provide some quantitative information on a scale of 0 to 12 or 0 to 16 or 0 to 20. The information is very large, has very large steps in its quantitation. And so these tests are mainly used for screening for color vision loss. The Ishihara plates can screen for red-green color blindness, whereas the Hardy-Rand-Rittler can screen for red-green or blue color blindness. They're very quick tests and easy to perform. The Farnsworth-Munsell test is an arrangement test where you have 100 different little blocks that you can arrange either on a computer screen or in real life to try and recreate this arrangement of different hues around the rainbow. If someone scores a perfect result, they get every single arrangement in the right order, and they have this black circle indicating 0 errors. However, if someone starts making a lot of errors in this area and this area, then they have a blue cone deficiency. This test does provide quantitative information about color vision, but it does take a long time to perform, on the order of 20 to 25 minutes per eye, and is in many ways not practical for the clinical workflow. The anomaloscope has also been considered the gold standard for measuring red and green color vision deficiencies, where within the anomaloscope, a subject will see a red and green combination of light passing through two filters, and they will turn knobs until what they see passing through these filters matches a reference. So they try to make this combination of red and green look exactly like their yellow reference. This test is very quantitative, only for red and green, and it takes about as long as the Farnsworth-Munsell D100. So both quantitative tests, but in many ways not clinically practical for a standard workflow. Today I'm going to talk about cone contrast threshold testing, which uses a digital display to evaluate individual cones one at a time. The L cones, the M cones, and the S cones, red, green, and blue. The background of the display is a uniform gray color. It is isochromatic. It's sufficiently bright to extinguish any responses from the rods, leaving only the cones to respond. And what the subject will see is a Landolt C optotype, which rotates in different directions, and they are asked to respond by clicking on a large keypad to indicate the direction of the Landolt C optotype. And then a quantitative evaluation is performed for the right eye and the left eye to indicate how much sensitivity and how much contrast sensitivity there is for each of the different L, M, and S cone options. So this is a tool that I started to use when I first began practicing in UC Irvine about 3 years ago. And I wanted to systematically evaluate its utility in a variety of different conditions affecting the retina and visual pathways. If we look at the visual pathways, of course, each eye has an optic nerve which decussates and crosses over in the brain and sends radiations back to the visual cortex in the brain. Multiple sclerosis is a disease that can affect any part of the central nervous system. And so all of these pathways leading from the eye through the optic nerve and back to the brain can be affected in multiple sclerosis. Multiple sclerosis happens to be one of the few conditions where color vision is actually routinely evaluated by neuro-ophthalmologists and neurologists to evaluate for changes affecting the visual pathways. I'm a retina specialist, and so I spend most of my time evaluating patients who have diseases affecting the retina. So as part of my practice, I evaluated patients with macular degeneration, which primarily affects the photoreceptors in the retinal pigment epithelium. Evaluated patients with retinal vein occlusion, which affects the blood supply to the inner half of the retina, and epiretinal membrane, which is a mechanical force that is transmitted from the surface of the retina all the way through the full thickness of the retina. So we have three very different retinal types of diseases: a vascular disease with vein occlusion, a mechanical disease with epiretinal membrane, and a metabolic disease that ultimately ends up causing death to photoreceptors and the retinal pigment epithelium. Of course, cataract surgery is the most commonly performed surgery in the world, and so cataract acts as a filter to change the amount of light entering the eye and reaching the retina. So we also evaluated patients with cataracts. So whenever using a new tool like a cone contrast threshold test, in this case I was using the Conan Color DX HD CCT. There are other versions of it. This is a cone contrast threshold test which tries to quantify both color and contrast sensitivity in subjects relatively quickly in about 7 minutes. So to use a test, you have to know how to use it correctly. And so we assembled a series of healthy subjects, all with great vision, all very young age, all equal a number of men and women, and we had them perform the tests. We had them perform the test with their eyes in the non-mydriatic state, undilated state, so basically just how you walk around every day. We dilated their eyes. We used a series of neutral density filters to reduce the amount of light entering the eyes. This is basically just a fancy pair of sunglasses that we systematically increase the darkness of the sunglasses. And we also evaluated the cone contrast threshold test using pinholes. And what we found was that, of course, with the neutral density filters, the sensitivity goes down for each of the different wavelengths. But the most important thing that we found was that we can't really reliably perform this test with dilation, and we can't reliably perform this test with pinholes because the error bars increase in size and the sensitivity goes down. So the results aren't always consistent like they are in the non-mydriatic, undilated native state. So this told me as a retina specialist that if I'm going to evaluate someone's color vision, I can't do it when they're in their dilated state, which is usually how I see them. One of the first things that we've done is we've tried to simulate what it's like to have a cataract in young, healthy people. So we have the cone contrast threshold test, and we have human subjects that are young and healthy performing the test looking through a lens that simulates a cataract. The first thing that we wanted to look at was how much of the different wavelengths of light are coming out of the digital display, the computer screen of the cone contrast threshold test. And so we see that the computer display has a peak just below 450 nanometers, a relatively broad peak around 550 nanometers, and another broad peak at about 615 nanometers. So this is the actual light that comes out of the Color DX HD monitor. We looked at how much light actually passes through the individual different lenses that are simulating cataracts. And we can see that a very light lens, which is shown actually as a photograph right here, allows almost all of the light to pass through it. Almost 100% gets through throughout the visible spectrum. Again, this is 400 nanometers to 750 nanometers. So blue to red light, and how much of it passes through the lens. And of course, as the lens becomes darker and darker, the amount of visible light that's passing through reduces. And this is one of these blue blocker lenses, which shows a slight reduction in the blue part of the spectrum, but relatively more light passing through the red part of the spectrum. We've used these different lenses to evaluate the cone contrast threshold performance when these lenses were introduced in front of the eyes of several subjects. I think there were 8 subjects that we used. And so you can see that without a filter, the results have fairly narrow error bars. They're all normal. And then eventually, once you get up to a fairly dark filter, you have a statistically significant reduction in the S-cone sensitivity. So although these are Browne filters that simulate cataract, they're not exactly like the neutral density filters that I showed in the previous slide, because they have a tendency to block blue light more so than all of the wavelengths of light, like a neutral density filter. So it was really at this very dark lens where we had a statistically measurable difference in the S-cone, the blue cone sensitivity. Next, we looked at actually a population of people, and we wanted to evaluate how healthy people, how their color vision changes with age. And so what we have here plotted on the x-axis is age of each of the subjects, ranging from about 6 years old all the way to people around 90 years old. And we looked individually at the S cone, the blue cone, the M, and the L cones. And what you'll notice is that in each of these plots, as people age, the slope of this line decreases. So people tend to lose color vision with age regardless. And you'll also notice that the slope is the least, minus 0.66 for the red cones, whereas for the blue cone, the slope reduction is the greatest, so minus 1.09. And that's what you would expect. These are all people that have their natural lens. They are phakic, and their lenses are aging. So you would expect that the blue light would be blocked. Pardon me. We then looked very specifically only at the age range where people might have cataract surgery. And we compared people who were pseudophakic, in other words, they had had cataract surgery, versus people that were phakic, who had not had cataract surgery. And the results were the same in terms of the trend for there to be a reduction in color vision across age. But there wasn't really a statistically significant difference between the colors other than really this red cone having a difference between the phakic and pseudophakic patients. So this is not something that we can draw conclusions from, but it can inspire us to do further investigations to try better understand how color vision changes after cataract surgery and how it changes with age. We actually did a study where we investigated 25 patients, 31 eyes, where we looked at these people's color vision before having cataract surgery. So this is when they had their crystalline lens with the cataract, and their color vision after surgery. And so clearly there was actually a statistically significant increase in all of the different cones after surgery, and the greatest increase was in the S cone, the blue cone. So the way that I look at this, and even though I don't practice cataract surgery, in the US, retina specialists don't tend to practice cataract surgery. I know in the rest of the world, retina specialists do a lot of cataract surgery. But the way that I use cone contrast threshold testing in my practice with other diseases is basically looking at how much contrast they can see and how much of a fall risk might they be. Because there have been many studies that have shown that cataract surgery reduces fall risks by improving vision in patients who have cataract surgery. So if I see somebody who is in their 50s, 60s, 70s, 80s, or 90s, and they have a significant reduction in their color vision, I do counsel them on improving, well, considering cataract surgery if they have cataract surgery, have a cataract, or improving the lighting in their homes and making sure that there are no cables or carpets that they could easily trip on. Like I mentioned earlier, multiple sclerosis is one of the few conditions where color vision is routinely evaluated in our practices, and is a demyelinating disease that affects the central nervous system that results in axon loss. And so early color vision loss is seen in multiple sclerosis with or without optic neuritis. And so typically we use one of these hard-to-read Riddler or the Ishihara color plates to evaluate this. But the site of injury of how color vision is lost in multiple sclerosis is not entirely known. The primary suspect are the anterior visual pathways originating at the optic nerve level in the eye. And dyschromatopsias do correlate with thinning of the nerve fiber in the optic nerve. So here's an OCT that looks at the thickness of the nerve fibers between this red and blue line as they dive into the optic nerve. And so color vision loss is associated with thinning of this nerve fiber layer. So we had a series of patients who we evaluated for color vision in multiple sclerosis and had age-matched controls. Actually, there were so we had 16 patients, and only 31 of the eyes were able to be included because the CCT can only be tested in patients with approximately 2120, 2130 vision. So one of the patients had vision that was below that, so that eye was not included. And we compared patients with multiple sclerosis to those who were age-matched healthy controls. So the first series of bars on these Violin plots are for healthy controls. The dark black line represents the mean for each of these test results. Then if we look at the next column, we're looking at people with multiple sclerosis who have no optic neuritis history. They have no history of experiencing a change in their vision or pain with eye movement that they can recall or was ever documented in their since their diagnosis. So what you do see is that there was a statistically significant reduction in the mean cone contrast threshold test for people with no history of optic neuritis. People with a history of optic neuritis, interestingly, not surprisingly, they do have a reduction in their color vision, but the amount of difference between the people without optic neuritis is not very large. So people with optic neuritis all have a reduction in their color vision and contrast vision, and this is expected. This is something that clinicians will use Ishihara color plates routinely for, but they can't quantify to this with this specificity. We also compared healthy people looking at the temporal or the global thickness of the nerve fibers. I'm going to go back to the OCT image here, where we have the temporal field here. Temporal field connects from the nerve to the fovea. This is the most important connection for color vision, because that's where the fovea with all of its cones sends fibers directly to the temporal aspect of the optic nerve. The global measurement would be the full thickness or the entire circumference of the optic nerve. So if we look at the temporal aspects and global aspects of the optic nerve, comparing healthy people versus people who have a normal nerve fiber layer and people with an abnormal nerve fiber layer thickness, we see that even people with normal nerve fiber layer thicknesses do, in rare instances for the N cone and the S cone, the green and blue, there's a significant reduction in the temporal part of the vision of the optic nerve that occurs in people with multiple sclerosis. And then people who have an abnormal nerve fiber layer thickness, the nerve is thinner. Of course, we expect that if there's thinning in the temporal part of the optic nerve, there's going to be a significant reduction in color vision. So the long and the short of it is that we have a quantitative test that can provide very specific sensitivities for an individual patient. And as we would hope and expect, it works in people with multiple sclerosis. These are the people who are being tested routinely anyways for the color vision. The next disease, and this actually started following more within my practice, is macular degeneration. And so this is the #1 cause of vision loss in people over 50 in the United States. People can have blurred central vision. They can have distorted vision. So on the Amsler grid, it can transition from looking normal with straight and right angle lines to having an area of distortion. People can have shadows, spots, or inability to see in dim light because they have reduced contrast sensitivity. And they can have possible changes in color vision perception. So here's a photograph, color fundus photograph of an eye with many large drusen from macular degeneration. And here's an OCT showing those large drusen. In macular degeneration, like many diseases, you can go from having a normal retina to with normal visual function to early macular degeneration, where you might have, and it's probably very difficult to see these small yellow spots and these very small drusenoid bumps underneath the retina on the OCT, to intermediate macular degeneration, where you have many more drusen, these yellow spots with drusen underneath the retina on the OCT, and you have loss of contrast vision in the central part of the visual field, to advanced macular degeneration, where you actually lose part of the central vision. And this can be of the dry form, where we actually lose the photoreceptors and the retinal pigmented epithelium in the central part of the fovea, or wet macular degeneration, where we have exudation, bleeding underneath the retina, and complete distortion of the retinal architecture. So this is where characteristic visual impairment is described for macular degeneration. So I'm going to show you a patient of mine who was 94 years old. He had cataract surgery in both eyes, 2040 and 2020. And with the way that we practice eye care, checking visual acuity as the only visual function test, you would say, oh, this guy must be really happy. He's got 20/40 vision in his right eye. That's good enough to drive. And 20/20 vision. Aren't we all looking for 20/20 vision? But the reality is that he's miserable with his vision. And so when you look at his color fundus photographs, you see the characteristic macular degeneration with a large area of atrophy in his right eye, small focal areas of atrophy in his left eye. And the autofluorescence imaging shows these dark areas of pathology a little bit more clearly. So when we look at his OCT, of course, we see that he has almost normal appearing central fovea in the right eye, and he has all the layers in his left eye as well, his 20/20 eye. When we perform color vision testing, we would hope that someone with 20/20 vision would have normal color vision that would be up in this area here, and below would be considered deficient. And so for him, his right eye, he sees only a little bit of red, almost no green and blue. And in his left eye, he has a significant reduction, well below normal levels in his 20/20 eye. And when I asked him what these colors look like on this report, he says, with my right eye, all of these bars look black. So he is 20/40 vision, good enough to drive, but he really can't see colors at all. So what we did was we wanted to compare healthy control subjects to people with early, intermediate, and either advanced dry or neovascular macular degeneration that was controlled with anti-VEGF medication. And what we find is that compared to healthy normals, it's at the intermediate stage of macular degeneration where there's a significant reduction in cone contrast threshold scores below the normal patients. And of course, people with advanced disease have horribly low levels in their cone contrast threshold scoring. So what we found here was actually not a new finding. This is confirmed by So we're actually confirming the findings by a group at Duke University in North Carolina, where they also found that cone contrast threshold testing is a reliable test for finding a significant reduction in patients with intermediate macular degeneration. So this may become a new standard for clinical trials, focusing on earlier stages like intermediate macular degeneration, rather than only looking at visual acuity, because people with intermediate macular degeneration can have 20/20 vision routinely. So this is nice to have a tool that can be used in clinical trials. But the way that I use it whenever I do color vision testing in my patients with macular degeneration is if I see a significant reduction, especially if someone has large reductions in their color vision and their contrast vision, I will counsel them on optimizing their lighting conditions at home and reducing any kind of trip or fall risks in their homes. Retinal vein occlusion is a vascular disease that primarily affects the inner retina, and here is a color fundus photograph of someone with a hemiretinal vein occlusion or a branch retinal vein occlusion, where you can see large amounts of hemorrhage within the superior part of the macula. The fovea is right over here, and the OCT, if you were to cut a line vertically through this, you can see that the top part, this is the top part of the macula, is very swollen, and the bottom part of the macula is almost normal. This causes acute changes in vision and with possible permanent vision decline. So I'll show you a patient of mine who was one of my first patients that I saw when I first started my practice. She came in with 20/60 vision that was acute in onset in her right eye. You can see on the infrared image here large amounts of hemorrhage within the retina, a very tortuous retinal vein, and the OCT clearly had a lot of macular edema involving the central fovea here. Her left eye was 20/20 with completely normal architecture. After several months of anti-VEGF medication, her vision improved to 20/30, and in her left eye she was 20/15. She actually ultimately has become 20/20, but has remained miserable with her vision in the right eye. She has a complaint that everything seems dull and blurred. And when we perform color vision testing and compared her right eye to her left eye, we can see that there is a significant reduction in her color vision in her right eye that she won't recover. Her left eye, surprisingly, actually has a reduction in color vision as well, but she's perfectly happy with her left eye. This just may be her normal. So she has a large reduction in her right eye that is very different from her left eye. The question that this raises is, we spend all of our time in clinical trials for retina diseases looking at ETDRS visual acuity, black and white letters, and we would say, you know, she eventually gets to 20/20. That's great. That's a success. But are there therapies that should be considered at the earlier stages of the disease that might actually preserve more of this qualitative part of the vision, the contrast and the color? So we compared in 14 patients their healthy eye, the eye that did not have a vein occlusion, to their eye that had a vein occlusion, and we see a very large reduction in their color vision scores in their affected eye, and that just mirrors exactly what I showed in that single case. Finally, we also looked at epiretinal membrane, which is I'll use the stage 3 epiretinal membrane to show the difference, where you can see this very fine membrane on the surface of the retina and complete loss of the foveal contour. In a stage 1 epiretinal membrane, you can see some bumpiness on the surface, but there still is a foveal contour, and that slowly gets worse and worse and worse from stage 1 to stage 4 epiretinal membrane. So this is a mechanical force that distorts the full thickness of the retina, not only the inner surface where the fovea is, but can actually cause distortion in the outer parts of the retina as well. And so we looked at people with grade 1, 2, and 3 epiretinal membrane, and we saw that there was a decline in cone color and contrast vision. So there is a significant reduction for people even with grade 1, maybe 20/20 epiretinal membranes. For me, again, I would always counsel patients on reducing fall risks at home, but I think this might become something worthwhile to investigate in people who are considering epiretinal membrane surgery in order to help to triage people who might have a better visual recovery from before and after epiretinal membrane surgery. So here's an example of one of my patients. who clearly has a severe epiretinal membrane, stage 3 to 4 in his right eye, and has a large color vision deficiency in his right eye. So the final case I'll show is fairly interesting in that this is a 34-year-old woman who has no past medical history. 8 months previously, she had been hammering a nail, and something flew and hit her in the left eye. She went to an outside emergency room where they looked at her and said that everything was fine, and she was given some artificial tears and maybe some steroid drops and told to use those until she felt better. So she eventually presented to us at UC Irvine 8 months later with progressive vision decline in the left eye. Her baseline evaluation comparing the right eye, which is 20/20, and the left eye, which is 20/60, she had a dilated pupil in her left eye. And if you look very carefully at the left eye, there's this little black spot underneath the conjunctiva, superior temporally. And if we looked carefully as well, she had some cataract formation with a little bit of pigment deposition on the front part of the lens, which indicates that there had been some small amount of inflammation as well. A wide field pseudo-color fundus image looks fairly normal, but hiding over here in the far periphery, there's something that's sneaking. And if you had to look in that direction, you can actually see that there's almost like this stake-like structure sticking into her vitreous. And she actually had some small vitreous opacities that were visible as well. We performed OCT imaging, and if you just look at the OCT image, these two look perfectly healthy. These are very normal-looking OCTs. If you're concerned about a piece of metal in the eye, you might be worried about the ellipsoid zone being damaged. But her ellipsoid zone is fairly similar between the two eyes. If you look at the thickness map, and this is not a great thickness map here, but this measures the thickness from the inner to the outer retina, and you compare the left eye to the right eye, you can kind of tell that there's a little bit more orange in the left eye, so a slightly thicker retina in the left eye compared to the right eye, which is orange, but not quite as orange. And if you look at the OCT angiogram, you might be able to say that it looks like the vasculature is slightly more congested, but very subtle. If we do the same OCT on a different machine, that was a spectralis, this is a Cirrus, which does different segmentation, you can see that there is a little bit more vascular thickening around the optic nerve, whereas the macula between the two eyes looks much more symmetrical. So there are some very subtle things that one can look for in the thickness maps of OCTs to suggest maybe there's a problem. We obtained an ERG comparing the right eye to the left eye, and we can see that the waveforms in the right eye are much larger than the left eye. The 30 Hertz flicker test, which evaluates cones specifically, we can see that in the right eye there are large waves that respond, and then in the left eye there are smaller waves from the 30 Hertz flicker test, suggesting that there is photoreceptor dysfunction and most likely cone photoreceptor dysfunction. As an academic type of investigation, we also administered pilocarpine because we wanted to understand why was her pupil dilated when there's no iris sphincter tears, and this was minor trauma, so we wouldn't expect to see that. And what we found that after pilocarpine, her pupil did come down, much more so than the right eye, even though the right eye did become smaller. But this confirms what has been reported previously, that toxic metallosis in the eye causes a parasympathetic dysfunction, and so basically the parasympathetic outflow to the left eye is reduced, and that is what's causing this toxic mydriasis. We performed a minimally invasive surgery, removing just the local vitreous that came to the wound. As this asteroid-looking body was removed, we pulled this piece of metal out of the eye, and we can see the electron microscopy image of it here. And we performed analysis of actually, this is her lens capsule. So she had cataract surgery, and we can see that there's Prussian blue staining in the lens capsule. So this is classic for iron. And we performed mass spectroscopy on the foreign body that was removed, and we can see that there's a large spike in the iron. So there's a significant, this was an iron foreign body that was causing toxic metallosis or siderosis to the eye. She had cataract surgery. The right eye before and after surgery didn't really, she didn't have surgery in the right eye. Everything stayed pretty constant. And then the left eye, we can see that The red and green didn't change a whole bunch, but she did have an increase in her blue cone sensitivity. So in conclusion, even in patients with good visual acuity, cone contrast threshold testing is a quantitative test that can reveal deficits in color and contrast sensitivity. And while we would expect it to be valuable in multiple sclerosis, it actually might have important value in other diseases that affect the retina, like epiretinal membrane, macular degeneration, and vein occlusion. CCT appears to be a potential clinical endpoint for all of these different disease states. And the real challenges to it at this point is that is integrating it into routine use. It is far easier to integrate than an FM100 or an anomaloscope. It's a fairly easy test to take. However, people do describe it as being hard because it doesn't start off as just showing a pure green letter. It's actually very difficult to see. For example, if you're looking at a green Landolt C, while that test is being performed, the green or red or blue becomes much, much dimmer over time, and it's very difficult to see it. So it's not an easy test, but it does provide reliable quantitative data. So our experience that we've had with cone contrast threshold testing at UC Irvine kind of informs us about how we can use it in our patients, but also how we can implement slightly easier tests to perform in the future. But you know, I found the test to be quite useful even in my retina practice. I don't have it performed on every single patient, but if there are patients that have 20/20 vision, but I suspect that they have you know, not a good 20/20 vision, then I do obtain the test so I can help to educate the patient and show them that they truly do have a reduction in their visual function and that they should optimize their living environment at home with good lights and reduced fall risks. There's a number of people that contributed to this work, including several medical students, several of my physician colleagues, and people in our lab. And these are the faculty at the Gavin Herbert Eye Institute. There are many of us that do research, many of us that are clinicians, and many of us that do both. And with that, I'll take any questions.
Great. Thank you, Dr. Browne. That was really great. Just a couple of questions. We have a question from an attendee in the UK that is asking if the fall risk increases after cataract surgery due to the sudden change in contrast. In other words, it suddenly gets better. Is that correct?
So there is an adaptation period after any surgical event or any event affecting vision where, you know, people can become disoriented and have increased falls. I'm not, at least I recently did review that about 6 months ago, all of the cataract surgery data and fall risks. There were some studies that suggested that there was an increase in fall, and I think it actually came out of the UK, so maybe it was that attendee's colleagues, or maybe that person in particular. So there have been reports of increased fall risk after cataract surgery, but certainly after any kind of event where your sensorium is changed, it's not too surprising during the adaptation period.
Great, thank you. Next question is, how do patients with amblyopia respond to the CCT?
So amblyopia is a disease that affects visual acuity, and of course has central neural remodeling in the lateral geniculate nucleus. The cones are still present in amblyopia, so the mapping of the cones to the visual cortex is disordered, and that has been associated with reduced visual acuity. We haven't studied specifically people with amblyopia, although I do have maybe 2 or 3 in my practice who have amblyopia, and I have obtained color vision testing. I haven't been all that impressed by the difference between the 2 eyes in color vision in that small number of people. So I think that's a population that's worth studying, and certainly in the context of children who are undergoing occlusion or atropine therapy for amblyopia, it could be a useful endpoint. You know, there are children usually around about the age of 5, or even some 4-year-olds who can do this test, but it is a test that does require some focus and attention. So just like measuring any kind of visual function test in a child, it can be done, but it does require maybe a little more patience. So I think studying amblyopia is something that's worthwhile studying in the future.
Great, thank you. So our next question is, so are you changing your protocol for PTs with ERM to do color vision and use that as part of your recommendation to do SX despite 20/20 vision, but noticeable distortion?
Yeah, this is something that's is very interesting. Actually, I have a patient that I saw 2 weeks ago who got 20/20 vision, has huge differences between his two eyes in terms of the quality of the vision, and he's I don't want to say viciously symptomatic, but he's very symptomatic. He's very unhappy, and so we've taken him very slowly through first getting cataract surgery. He said that helps, but it's not the reason why I'm here. I have a problem with metamorphopsia between the two eyes. He has a normal foveal contour. I am getting a color vision test on him to see how significant it is. In those kind of more borderline cases, certainly 20/20 eyes are not eyes that we want to be doing surgery on. 20/40 is kind of what my threshold is. So for people who have 20/40 epiretinal membranes, I definitely will get a color vision test to assess the reduction in contrast and color, and help them make a decision. Never ever want to push anybody towards surgery, but you want to provide them with the counseling that and the subjective and objective data that can help them make that decision. For me, I am going to be using this test as part of a research protocol to understand how color vision and contrast vision can change before and after really any surgery, but epiretinal membrane surgery is one of the most interesting ones to me.
Great, thank you. And last question is, which color vision test is most accurate and recommended for an optometric office?
Well, that's a really interesting question. Which one is the most accurate and recommended? I don't know if the optometry societies around the world have expectations of what tests are used. Certainly within ophthalmology, the only thing that's been used at any of the practices that I've trained at or that I practice at, the only test that was ever used was an Ishihara color plate. Certainly for clinical trials, there were FM color arrangement tests, usually only with 25 palettes, 25 just to make it practical from a workflow. But when you're talking about the most accurate, and I think that any of these tests that start to allow greater quantitative resolution, they're very similar. We haven't studied people with color vision deficiencies using the FM100. And I won't do that because I can't have my patients spend 30 minutes arranging the colors in the FM100, and the anomaliscope is not something that I'm going to focus on either because it neglects to address blue vision. So what is the most accurate? I think they're all accurate at detecting, at quantifying and detecting a color vision deficiency. I see no reason not to use any one of the cone contrast threshold tests that are available. Certainly, I've been very happy with the one that Conan makes, and it's given me reliable results in investigating macular diseases, as well as cataract surgery changes. So, I just don't know how to answer what is the most accurate. I think they're all accurate, but the only difference is that the FM100 and the anomaliscope just aren't practical.
Great, thank you. And the last question, with EPM peels, do you see significant improvements in color vision?
I haven't done that study yet.
Okay,
that's definitely something we're starting to enroll people in, but we haven't. And the thing about that study is that's one that needs to occur for at least a year, because people's improvement in qualitative visual function takes about a year for them to reach a steady state. If their retina has been distorted for some time before surgery, it takes time for it to kind of get back to a normal again. But that's definitely something we want to study.
Great. Well, Dr. Browne, really appreciate you spending your morning presenting this information. I thought it was great. I hope the audience enjoyed it. Thank you for everybody that attended, and have a fantastic week.
Thank you, everybody.